Perfect. So welcome everyone to the May Telehealth Learning Collaborative. We're doing things a little different this time. So normally we do our state updates in the beginning. We're going to put those to the end just because we're waiting for a few partners who have some conflicts to come in. But we're having a little bit of an issue on one end audio-wise. So just give us a minute. Okay, Caitlin's going to try calling in and see if that works. I have a couple housekeeping items that I'd like to just run through. For anyone who is on today and you get the link and you know that you're planning to attend, if you can please register via the WebEx link. I get a lot of the tracking approvals from Outlook, which is great, but we do use those registration numbers for tracking to the state. So if you can please register ahead of time, that's perfect. We do keep track of attendance, but it's always nice to have both kind of secured on there for state purposes. I also noticed that I want to make sure we all have our meeting hold. So after this meeting today, I will go in and take every other one of the telehealth learning collaboratives for the year, which is July 20th, September 14th, and November 16th. And I will take them and add them to everyone's calendar as a hold. That way you have a placeholder just in case things come up and it gets busy pretty quickly in the year. And then the other two things were presentation interest and specific topics. If you are really interested in a specific topic of telehealth that we haven't shown, or something that we showed a few years ago and you'd like to see again, or just anything, please reach out to the telehealth at ahihealth.org email. I'm happy to try and find someone who speaks or presents on that topic. Also, if you have a presentation of interest that you would like to share, programs and anything like that, I'm happy to put you in the calendar where we have openings. So just to keep it out there, I will be putting that in. I'm also working on a newsletter to go out. So again, same concept. If you have programs, initiatives, any recent successes you want to share, please let me know and I'll put that in there. And yes, I'm happy to do the calendar holds. It helps keep me accountable, which I like. And then the only other thing I'm going to put in the beginning, because I don't want to forget to mention it, and you'll hear me mention this a million times, is the North Country Leadership Summit. A lot of you know about it. For those of you that don't, it's a conference between AHI and Fort Drum Regional Health Planning Organization. Together, we put on the North Country Leadership Summit. It takes place in the fall. This year is September 30th and October 1st at the Lake Placid Conference Center in Lake Placid, New York. It is a mix of population health, telehealth projects, or presentations, but it's anything across healthcare. We are fully open as of right now to call for presenters, award nominations for both telehealth innovators and rural health champions, which are anyone that you feel is standing out in their field on either telehealth or population health. Please submit a nomination on their behalf, and they'd be in the running for one of those awards. And then sponsorship as well. New to this year, we're doing posters. So in the past, we've only ever done presentations, standard breakouts, keynotes, panels, plenary, that type of thing. This year, we're also doing posters, and we're mixing up the venue spacing a little bit in hopes that we can kind of make sure that everyone is represented. I feel like sometimes we get presentations in and we don't really have a good way to keep some of those more niche presentations available for viewing, but they're important. And so hopefully the posters will help with that. So just keep that in mind. I will put the link in the chat and I will also put it in the notes. And then in that being said, Caitlin, you said you're available on audio. Can we test it?
Yes. Can you hear me?
Yes, we can hear you.
Thank you. I'm so sorry, everyone.
That's okay. Jess was ready to wing it. So let me go ahead and share my screen. And then you have your slides in front of you. So I'm just going to start it on the main slide and you guys can kind of tell me where to go. Caitlin, if you need a question on what slide you're on, either ask Jess or myself and we can have it set up.
Perfect.
Okay. Let me just. Can you see the slide? Well, not you, Caitlin, but everybody else.
Yes.
Perfect. All right, so I'm going to turn it over to Caitlin and Jess to give a presentation on the Dartmouth Health TeleICN Connected Care Center.
All right, great. Thank you very much, everyone, for having us today. I'm Katelyn Darling, Director of Operations for our Center of Connected Care, and then Dr. Jess Clem is with us as well. She is a neonatologist and our TeleICN Medical Director. Next slide. So first, I'm just going to do an overview of Dartmouth Health Connected Care. Kind of our vision is to use telehealth to build fundamentally sustainable health infrastructures that address the primary rural healthcare challenges of access, workforce, quality, cost, and transportation. Our mission is to really help deliver outstanding care to our region independent of patient location. And we have our focus is really on rural healthcare, and our goal is to keep care local as much as possible. Next slide. So this is just a map that outlines all of our connected care service locations. So as you can see, primarily most all of our locations are in Vermont and New Hampshire, and most all of the hospitals that we work with have a variety of our different service lines. We are also doing some stuff in Maine and Massachusetts, and our telepharmacy service line actually does have some stuff at Methodist in Houston. Next slide. So this slide just shows our connected care volumes over time. So as you can see, calendar year 2026, we weren't doing that much, but you slowly see growth, and probably like a lot of you did in 2020 when the pandemic happened, you saw a huge transformation in growth. So all of our service lines grew, pretty drastically that year, and they have kept growing since then, which is exciting to see that this trend is still going up for us in that space. Next slide. Right, so this is our Dartmouth Health Connected Care service line. So these are kind of our more robust service lines. We're really here to talk about the TeleICN service, but I thought I'd just briefly mention our other service lines and then go into a little bit more detail about two of our other more robust service lines. So we have TeleED. They've done over 400 bedside encounters with a very high satisfaction rate. Later in the presentation, I will show a little bit about how TeleED works nicely with TeleICN in some hospitals. Our central monitoring hub, so that's 24/7 telemetry for over 200 inpatient beds. So we do have 5 tables in our location as kind of a hub that are trained monitoring techs watching over those inpatient beds. Our telepsychiatry service, we've done over 4,000 consults to date. Our mean response time is 18 minutes. For our pediatric population, 52% of those patients were able to be discharged after a consult, and 66% reduction in length of stay for those patients as well. And then our telepharmacy service has done over 6 million orders to date, and their stat orders are responded to in less than 5 minutes. So very briefly, I'm just going to talk about two of our other more robust service lines. So if we go to the next slide, the slide 6, Dartmouth Health Teleneurology. This is a 24/7, 365 service that's available to EDs, med-surg units, ICUs for adults. We do have different response times. So if it's urgent, we're going to respond in less than 30 minutes, non-time sensitive, 120 minutes. And then some of those routine inpatient consults can be done within 24 hours. What we're starting to do now in teleneurology is really look at some of those benefits to patients of retaining patients locally. So we're getting to a place where we can really do a deep dive into the data to understand how many patients are really able to stay local at your facility and what that ROI is. So I wanted to bring that to this group as just kind of a learning collaborative to see if other people are doing similar research in that space and if there's room for us to kind of collaborate on what we're finding and others might be finding. Next slide. So this is just our Dartmouth Health TeleICU service. So this one has been around for quite a while as well. So it's board certified intensivists and experienced clinical care nurses that are providing 24/7 collaborative care. The response time is an immediate connection to the hub, and they're hardwired beds that are directly connected right to the ICUs. The next slide for this just goes into a bit more detail about the ICU service. So this would be slide 8, where it's strengthening rural community care. So it's really improving access to that high quality critical care, supporting rural hospitals to really help keep patients local, and build a resilient future-ready care network. The strategic objectives is really to keep patient care local. You'll hear that a lot as being, part of our mission and vision. And it's really to help expand regional capacity. So making sure that we're using the beds within our region the best we can. And some of the outcomes we've seen from that are reduces in transfers, shorter length of ICU stays, and it's reduced mortality and complications. So now if we go to the next slide, slide number 9, we're going to start talking about our TeleICN service, which is kind of what our primary discussion today. So this was established in 2016 is when we first started our TeleICN service. And it was really a result of multiple deliveries, both term and preterm newborns throughout our region. And we were working to, respond to the need that there was out there, being the only level 3 neo-intensive care unit in New Hampshire. So we were aware that our team, we can't be at all the hospitals that might need us, but we could use telehealth to be at the bedside. So that is why we started offering this TeleICN service to really try and help support those hospitals the best we can. So on slide 10, we're just going to get to know our team a little bit. So Dr. Clem, who's with us today, she is our TeleICN medical director. Myself, Katelyn Darling, I'm the operations director for Connected Care. We have Brittany Sleeper, she is our manager of Connected Care. And then Liana, she is our program coordinator, so she helps us with a lot of behind the scenes things. And then we have a 2-man IT team, which is pretty amazing for all the services we have, so we always take our hats off to them. But Jamie and Fred, they do an outstanding job for us. So now I'm going to go ahead and turn it over to Dr. Clem to talk a little bit about the clinical team and the clinical aspects of the service.
So this team that you see in front of you is the neonatology team at Dartmouth Health. So the 7 of us are board certified pediatricians and neonatologists who are working actively in the level 3 unit at Dartmouth with the goal of both providing care to babies in front of us and also to provide care for babies regionally. Next slide. This is a sample case for one of the ways that we have been involved in the past. We have had multiple instances where it was apparent that a transport was necessary in advance of the patient actually being delivered, but our goal with TeleICN is to really bridge the gap until our team can arrive. So in a small northern New England hospital on an overnight shift, an ambulance brought in a mom in preterm labor. As you know, in many birthing units, when there's no active patients, the only people present were 2 nurses on the unit. The midwife, pediatrician, and obstetrician knew that they were needed, but were on their way and not yet available at bedside. Mom was wheeled into the room already pushing, and the baby's head was visible. One of the nurses had never actually attended a delivery before, and so she realized that when the mom's contraction stopped, she had a window to act to get extra support, and she opened the TeleICN app. Within moments, the transfer center had paged a neonatologist who was able to join via secure video to be able to see both the patient setup and the room in which the baby was going to be delivered, and to help guide the team in creating a plan, both pre-birth, after birth, and in the transition time before our team arrived. Everybody was assigned a role, and that real-time support allowed sort of the frenetic energy of an unplanned emergency to be a little bit calmer so that everybody knew what their next best step was. They were able to get direction and I think just feel a little bit more secure about an unanticipated and rare event. That baby was delivered safely, stabilized by the local team, and ultimately transferred to Dartmouth Hitchcock by our neonatal transport team. Our goal really is so that every baby who needs help is able to get timely care in the location that best serves them and their family. Next slide. We really have a 2-pronged goal. The first is really to support parents, providers, and staff. We want people to know that we are available for a wide variety of diagnoses for infants less than 28 days of age. And our goal is primarily to keep patients and families close to home. We really value the maternal child dyad and know that keeping babies with moms and dads is incredibly important. We serve as a place for recommendations, decision making, evaluation, plan creation, and sometimes just confidence boosting that the outpatient providers are really already on the right track and that we wouldn't be doing anything different than the care that they're providing. We are able to help in the times that babies do need to go elsewhere to arrange for a transfer or transport to a higher level of care. Our second goal is really to acknowledge that we are specialty care. We are a very niche market in medicine. What we do is not routine. It is not part of anybody's everyday practice except ours. And we really do not follow the normal physiology algorithms provided on a national level for emergency resuscitation. We are a different pathway. So what we want people to know is that we can be helpful by being immediately available to help people remember that babies are in fact not just small humans. And we really want to be able to facilitate a faster diagnosis and treatment in order to be able to keep babies where they belong, which is locally with their families. Our goal really is to help support regional hospitals retain patients, and we're able to do that by visualizing the baby and creating a care plan with the family and outpatient providers. Next slide. You have access to a board certified neonatologist 24 hours a day, 7 days a week, 365 days a year. And that access is provided to labor and delivery units who are part of our regional team and also emergency departments. We want you to be able to pick up the phone and call the Dartmouth Health Transfer Center and to be able to be connected to a neonatologist by video link or by phone, depending on your needs. We want you to know that it is incredibly expensive to have access to a neonatologist in-house or readily available for full coverage. So what we offer is a lower cost solution for hospitals that don't have a budget for a local neonatologist. We want them to be able to get the same level of service they would get by delivering in a higher level of care and to be able to assist with transfer for the babies when it's medically appropriate. We really want people to know that we are helping to facilitate faster turnaround to get babies where they need to go and to allow the local teams to do the job that they need to do, but then also to put their focus back on their normal level of patient care. Next slide. You may have heard regionally and nationally about some maternal health care deserts that have come across our region and country. We have a problem with maternal health in this country, and in the last 10 to 15 years, a significant number of both national and regional local birthing units have closed. The financial strain is significant, but the burden that it places on patients and families is astronomical. Next slide, please. When patients need emergency care, they actually don't care if you have a labor and delivery unit in your hospital. They will just show up in your emergency room. Emergency medical providers and local paramedics and EMS providers are not mandated to have training in neonatal resuscitation. Many do. It may have been years ago. It may have been something that they thought they were never going to need. But with this becoming a more visible and increasing problem, both in our state and country, the vast majority of EMS providers are realizing that they are underprepared for the rare event of a significant infant delivery needing help. The nice thing is that most of the time they're going to get the Buick baby. Oops, just didn't quite make it to the hospital, delivered in the Buick in the parking lot. For the small minority who need help, they are great at all of the mechanics of doing the resuscitation, but they really appreciate guidance and using a second set of eyes and a second brain to help guide a different algorithm for pathophysiology that is really different than somebody who's already been born. We want to help support them. And so we've been able to connect by increasing our services, not just to labor and delivery units, but also to ED departments and working with regional EMS providers on training. Next slide, please. We're able to help them before the baby's born. Everybody has a warmer somewhere, but most people don't know how to set it up. So helping them remember the simple mechanics of setting up the radiant warmer, making sure their equipment is set appropriately and correct, making sure that it aligns with the most current and up-to-date neonatal algorithm, which is probably not what they were trained on. We want to be able to help them actually lead the resuscitation so that our eyes and voice can be with them guiding the resuscitation to help with evaluation of how the baby's doing and provide management guidance during the resuscitation. We've also been able to facilitate consultation with families in incredibly challenging circumstances where care, even at the highest levels, may not result in an infant that survives. We've been able to help people prepare for extremely premature infant delivery and also to assist with transfer. Next slide.
All right, so this slide talks about our kind of our implementation process. So once we have a site that is interested in our TeleICN service, what we'll do is start the pre-work and implementation. So our implementation phase can take between 3 to 4 months. The main driver of that timeline is really the time required to credential the neonatologist at the hospital. So for pre-work, we get the proposal ready, we send that to our sites for agreements, we start drafting the contract, we'll start doing our credentialing process, and then we'll start understanding what IT needs to be established. So then we'll do weekly implementation meetings, and in those meetings, we'll discuss updates about the credentialing, updates about the IT setup, what kind of equipment we're going to be using. We'll do a deep dive into all of the workflows to make sure that those work for the sites. And then once all of those things are complete, along with the credentialing, we'll do our go live and on-site training. So that's when we'll actually go on site. We'll do testing the connections of the iPad, some live NRP drills, and review all the workflows. And then after that, after we're live, we will continue having monthly meetings to discuss their data, the workflows, any challenges they're having, any success stories that we have coming from the service. So that is kind of our implementation and our responsibilities and timeline. Next slide. So this is our TeleICN workflow. So when we do have a consult from one of our sites, they'll call our transfer center to initiate the consult. They'll provide some demographics and clinical information, and then the site will get the cart or iPad to move to the patient's bedside, and we will page the neonatologist to log on. The neonatologist will connect to the cart or the iPad and evaluate the patient with the assistance of the site team. And then the neonatologist will discuss the assessment and recommendations with the site. They can assist with calling the transport team if that's needed as well. And then we will do documentation and make sure that gets sent to the site so that they have that on file. Next slide. So the next bit of slides here just kind of go into some more of like the nuts and bolts of the service. So one thing that we like to do to try to make this service easy to access for our hospitals is give them cheat sheets. So this is just an example of a consult request form that what we'll do is have it printed out at the site, we'll laminate it, and we'll hook it right onto the technology. That way, when there's a TeleICN consult, the information is right on there to call this number, request this consult, and give us the following information. It's not something that they need to fill out and send to us, but it is really just to use as a guide to really help them with those urgent situations. Another thing we'll do, which I'll talk a little bit more in our lessons learned, is that we don't require them to give us all of the demographic or clinical information. If this is an emergent case coming through, we're not going to take the time to do that. We're just really going to bypass it, get the neonatologist on, and then figure out in the background how to get the rest of that information. Next slide. So this is just a technology overview. So we really try to take on all the responsibilities of setting up the technology for our site. So we'll complete an assessment and help to configure hardware. We'll work on ordering any hardware that might be needed for the service. We support the installation of it. We'll do all of the testing. And then we do provide 24/7, 365 IT support. We do that for all of our service lines, so that's another shout out to our two-man IT team that I mentioned in the beginning with how great they are to really support all of these services 24/7. From the site side, we try to make it as easy as possible. So, just attending those implementation meetings and assisting us with the connections and so forth. And in our lessons learned, I'm going to talk a little bit about the difference in these two technologies. So, we really like to use the iPad on a stand for the service, but sometimes a cart is what makes sense for some locations. So when I get to that slide, I'll give you a bit more detail on that. The next slide, so slide 22, talks about our TeleICN contracting process. So once a site has said, yes, we would like to initiate, the TeleICN service, What we do first is have a master telemedicine services agreement signed. So some locations you might call these master services agreement, but at Dartmouth we call them master telemedicine agreements. But it just establishes that foundational terms of our partnership, the roles, responsibilities, all of the legal provisions, and then includes the BAA if that's not something we already have with our sites. The next piece of the contracting process is to look at your statement of works. So that really defines the TeleICN service in details. It outlines what to expect, so what those SLAs are, response times, et cetera. And then we'll go into those technology requirements as well. For credentialing, we do really like to get proxy credentialing agreements with all of the sites we do provide services at. It does really streamline the credentialing process. It helps everything run more efficiently. We do have one site currently that does not sign the proxy credentialing agreement with us, and it is very time consuming to kind of do with those reappointment packets every time. So it is important that if you can get a proxy agreement in place, to definitely go for and push for that. So we'll do next slide, and I'll turn it back to Jess to talk about the TeleICN trainings and go live.
So in the middle, you'll see Dr. Michelle Tyler. She is doing a go live during the COVID era. It looks vintage at this point, but this is what we offer for the majority of our go live. So our goal is really to have somebody on site to go through the protocols that they have available, help them to update them, give tips and tricks for things that have worked for other regional hospitals. We also pair that with neonatal resuscitation simulations. So either going over recent cases, questions they might have, worst case scenarios, things they're most worried about, doing some hands-on training with our simulation dolls. And then we're able to work on practicing connecting with the technology and reviewing the workflow. So showing them how things work, how best to position things, how easy it is to use. If you know how to FaceTime, you can TeleICN. So it's really just showing people so that they believe that in an emergency, it's really just that easy. Next slide. We then also are able to do some continued work in education. So whether that's, regionally meeting every now and again to go over recent cases, going through just connecting periodically so that people have just-in-time training and it's fresh in their mind, doing neonatal resuscitation sims virtually, or doing drills through telehealth. So it's really helpful, especially if you have a lot of new staff, to reintroduce the concept periodically. And we're able to reconnect with all of our local sites on an as-needed basis to make sure they feel confident using the skills. Next. So really our hope is that we have as much time as possible, and we really want to make sure that we can facilitate as much as we can with our compatriots as well. So there are ongoing progress in the maternal health space with MFM tele support and OB support coming in sort of the next phase of life. But right now, when a mom is in labor, our goal is really to have a neonatologist available ahead of time to prepare the team and assist in roles and technology and equipment readiness. We also have TeleED that can help both for mom and the newborn anytime, anywhere. After birth, we are able to be with the baby as they move out of the operating room or the mom's birthing suite to be in the newborn nursery or wherever the resuscitation bed is in that local hospital, to be able to visualize and focus on baby's care. The ED physician can then stay back with mom to provide adult care, because it's been a long time since I've cared for a grown-up. And so I really like to move with baby, which is why the moving iPad is really helpful. Next.
All right, so this is just talking about the financials for the TeleICN program. So we do have some service fees and then the different clinical payment models for it. So for the service fees, we will do a one-time implementation fee, and that's really just to help support the workflows, the configuration of the technology, and primarily the training of our team to kind of go on site and do all of those trainings, et cetera. And then we do have a monthly support fee. So that is kind of the provision, using the telehealth iPad, the 24/7 IT support, any ongoing trainings, credentialing, et cetera. For this, though, we have the ability to waive it. So if one of our other services lines might be active at that location, then we can waive it at times. So that monthly support fee can be dependent on what the hospital might already have. For the clinical payment models, we really have two different models. So we have our subscription model, which is usually best for labor and delivery units. So how we do this is we base the subscription on the unit size and the annual number of births. And then we look at those historical consult calls coming into the transfer center to determine the average number of calls for support. And then we assume that when a neonatologist is doing this work, they have their hourly rate that they use. So we'll say they take them 90 minutes times how many consult calls are coming in, and then what that kind of salary looks like for them to come up with our subscription model. The other option was something that we really put in place when we started talking with ED-only sites, because they don't want a subscription, right? They don't want to be paying for something that they hopefully never have to use in the ED. So instead, what we did was we just did it as a per consult fee. So we're going to be live and available to you 24/7 for this service, but you will only pay when you see it and when you use it, I'm sorry. And then what we did was we really based that on what that hourly average for a neonatologist would be. So we'll say 90 minutes per consult, what is that salary? And that's what we're going to charge our sites. So that really seemed to be the most cost-effective option for the ED services. We don't do any professional billing in this space, just because when you are doing a per consult fee, that can look like double billing if you're also billing the patients. And it was just easier that way because it's too challenging to understand which hospital should I bill for and which one should I not bill for. Next slide. So these slides, the next few slides just talk a little bit about our TeleICN data. So our total consult volumes is we've done over 350 consults since going live. Some of you might say, wow, for 10 years, that's not that many, but I think that's kind of a good thing, right? We don't want a lot of these emergencies happening. We really want to try to be proactive in preventing them in the first place. So that's our volume. We're live at 16 sites. Again, that retention rate that I talk about often. So for our labor and delivery units, 55% of patients are able to stay local after having a TeleICN consult. Then below just shows our percentage by the time of day. So your daytime hours are the highest percentage, and then the percentage by day of week. So Thursday and Friday are busier, Saturday not as busy. Really no rhyme or reason that we can think of for that, but that's the data for that. The next slide, 28, goes into some of our site satisfaction. So we're able to do post-call surveys to get the experience from the bedside teams. And with those surveys, 100% agreed that using TeleICN improved the baby's care. 100% agreed that the technology was easy to use. And 95% agreed they were connected to the neonatologist promptly. So together, these results really do show that, TeleICN can increase the clinical confidence, support that timely decision-making, and really helps to ensure that the newborns receive the care they need when and if they do need it. So next slide, we'll talk about the neonatologist staffing, and I will turn that back over to Jess.
So we are all full-time employees at Dartmouth Health. We are already working our normal daily jobs. The person who is taking the call for TeleICN is usually the person who is on service in the NICU at Dartmouth. Occasionally, it's a person who is on our consult service, which is our outpatient consultation for antenatal consults for moms expecting babies who might need NICU level care. We're already taking calls, so it's not really a change in our workflow. We historically have done most of this by phone. For us, the value is really in video. An extra set of eyes is priceless, and it allows us to think about things that perhaps the outside providers are not readily worrying about because they're really focusing on like the ABCs, just getting airway, breathing, circulation under control. Having a visual allows us to think about alternate diagnoses, expedite decision-making, and really reduce the amount of time that people are spending worrying about sort of things that may not really blow my hair back, or things that really do worry me that perhaps they haven't noticed yet. The subscription revenue is then used to justify hiring additional FTEs to support the clinical staff in the ICN. So our goal is really to use the expertise of the neonatologist, to use the benefits of technology. You know, there's pluses, minuses to all things, but for us, the technology has really changed how we care for patients from afar, and to make things faster and to have more information available as we care for babies that are at a distance. Our goal really is to have better care for newborns and families and to make sure that that care is expedited. People might call us for all kinds of reasons. So oftentimes people like to have us present for resuscitation, especially if they think it's going to be a doozy. So whether that is some concern antenatally or a worry about an extremely preterm or preterm delivery, they like to have us available ahead of time if possible. Oftentimes for premature C-sections, we can be near the OR, ready to help people resuscitate after delivery for the teeny tinies. We often help kids with unanticipated respiratory distress, so the term baby that needs a little bit of extra help that nobody predicted. We're also available for full code resuscitation support for the ones that nobody really expected. The video is extremely helpful for things like physical exam anomalies, so whether it's sacral dimples, an unusual marking on the baby, asymmetry, things that are more subtle, but people are wondering about genetic diagnoses or underlying conditions and just want help thinking about next best steps. We can also be helpful in babies with failure to thrive, acute pneumothoraces after delivery, or difficult deliveries like a breech extraction.
All right, so our next slide, 31, talks a little bit about some of the lessons learned. So one of our lessons learned, I kind of alluded to it before, was our intake process. So during an intake for a TeleICN call, we really try to collect mom's info, baby's info, reason for the consult. But as I mentioned, sometimes in these acute and urgent situations, there's really no time to gather this information. So what we've decided is if time allows, we will gather it, but if not, we just bypass our intake process altogether and immediately page the neonatologist to join the bedside team on the iPad to start the consult. After things have settled down, baby stabilized, we will then call the site back to speak to the secretaries or the RNs on the unit to get the information we need. So it's really about kind of making sure there's never any hard stops in your process, because sometimes when those urgencies come up, you just have to be able to pivot and work around them. Some other intake tips and tricks that we've learned is really figuring out how to leverage your EMR for automation. So we worked within our EMR to streamline our intake process. We have Epic, that's the EMR we use. So when we create our intake shell, we found ways that it can automatically capture some of the data we're looking for. So our intake times can automatically be captured. The referring location can automatically be captured. So things that you can leverage within your EMR to make it a faster, more streamlined, efficient process is great. And then also have a backup option. So sometimes if a caller is calling, they get a busy signal, they've been waiting too long. In those urgent situations, it can be really stressful. So what we learned was a way that if the call is not answered within 3 rings, we can automatically push it to another phone line where another transfer center or support staff can help answer the call and get things started, instead of somebody just sitting on hold and getting more anxious while they're waiting. So having a backup option to help you in those urgent cases is great. Next slide. So just a few more lessons learned. So we find that using iPads in the delivery and labor and delivery units are the best way to go. The iPads are small, they're portable, they're easy to position, and it really, there's not a lot of room near the baby's bedside. So by having the smaller technology, it really helps to maximize the space for the care team that is around the baby. It's important to also test the iPads regularly. So on a weekly basis, we have our team go on and call the site and say, let's do a test connection. So we're making sure the technology is working appropriately, but at the same time, we're also ensuring that the bedside team is continuing to remind them how to log into the iPad, how to use the iPad, so that in those urgent situations, they're more used to doing that kind of workflow. When we started focusing on the non-labor and delivery units, we realized that a lot of these hospitals already have IT or telemedicine equipment in their EDs. So we didn't want to give them an iPad to have more technology. Instead, we said, let's align our technology and workflow with what they're used to. So, for example, a hospital that had our teleneurology service already that they were using regularly, we said, let's mimic the teleneuro workflow. Let's use the existing teleneuro cart. So that way, when an urgent case comes in, which for these EDs might be once a year, there is a workflow that they're used to. There is technology they're used to. So it's about being flexible to use what they already have so that their comfort and they're more familiar with it in those urgent cases. And then on occasion, we still have issues with our documentation, so that's just something we're continuously improving. It's how to make the note as efficient as possible, how to ensure that it's automatically getting routed and received at those locations, how to make sure the locations are uploading them. So that's just kind of a constant theme that we're continuing to address. So I'll go to the next slide, and this is really where we're going to open it up for questions. I think these slides will be posted somewhere. We do have a little appendix with some of the rest of our Dartmouth Health service lines in case anybody is interested in talking about those or collaborating about other services. And I do apologize. I had some technology glitches, so I'm not on video. So I am sorry about that. But opening it up to questions from anyone for myself, Dr. Clem, and we also have Dr. Kevin Curtis in the background. He's our medical director for Connected Care, so anything not ICN related that you might have questions for, he's available to answer as well.
Perfect. I'm going to stop sharing so I can see the questions, but I kind of quickly scanned through the appendices just in case on there as well. Does anybody have any questions? Wendy, not yet, by the way. I did see your comment and I haven't had a chance to respond. What I'll do is, so I will take your slides and some of the information you already sent me, Caitlin, that'll go in the notes. So if we don't have any questions, then I will send them your way if we get any in the meantime. It brought back a lot of, my youngest was born and had to immediately go into the NICU, and they had an iPad there, and it brought me right back with some of those pictures. So it's right back in the room. She'll be one in a couple weeks, but it was definitely scary at the time. We have one question. What is the typical amount of time to set up the IT services between the participating parties?
Yeah, so if it's an iPad-based service, it doesn't take too long to do. We use, our platform that we use is called VidYO. So we'll get the iPad out. We'll make sure it's connected to the Wi-Fi. Another thing to make sure to do is that it is a patient iPad, right? So you don't want any of your EMR login, stuff like that on it. You really want it to be that patient-focused iPad. And then we will provide the app for them to download from the Apple Store or the Google Store if it doesn't happen to be an Apple iPad. And we will provide a login. So we'll use VidYO and tell them this is your TeleICN room, and we'll get them logged into it. So it doesn't take too long if it is iPad-based. The cart-based services do take a little bit longer because we do have to get them on the Wi-Fi and on the server. So for those services, they can take up to, about a month to ship and get everything set up. But the iPad-based services, they're pretty easy to do.
And on the iPad, what version of iOS is the minimum that's required? Or what version of iPad hardware? I know you said maybe it won't be an iPad, so are there specific requirements on your end?
There's really not any specific requirements as long as the site can download the VidYO app on it, which we have some very, very old iPads that can still do it. And we've put them on Surfaces and other things, or just an old laptop could be used as well. So really, it can go back as far version as some of those technologies are. It's just downloading the app.
Okay. Trying to add it on here. Does anybody have any other questions? don't see anything on here. So rather than make everyone wait in silence, I will, if there's any questions, I will send them your way. Thank you guys so much for presenting today. This was really fascinating and it's great work. And we appreciate you. So thank you so much.
Good to
Thank
if
you
you
very
guys
much
have
for
to
having
answer
us.
questions offline.
Yeah. All right. So we did move the state updates that we had to the end. So I haven't checked on here. Casey, I'm going to see if Casey's on here. If you are, feel free to shout. Casey, you are on here. If you want to go ahead and open up your line, please feel free. Casey DeBellis from New York State DOH. I saw her name. While we wait for Casey, I do have um, Anna Kane from New York State OMH. I asked for any updates. The update we have right now is a work group has been established to guide efforts to amend the Part 596 telehealth regulations. The goal in mind is to present regulation amendments to the New York State Office of Mental Health Behavioral Health Services Advisory Council in July. More to come on that once that's been released. And I don't see Casey. Casey, can you, let me see if I have to request to unmute again. Try now. There we go. Did it work?
This is Casey from Medicaid. Is anyone able to hear?
Yes.
Oh, good. Okay. Thank you for your patience with me. I'm not sure what my issue was there. Hi, good afternoon, everyone. My name is Casey DeBellis. I work for the New York State Department of Health Medicaid program on telehealth policy. Our one update today is that we recently launched coverage of 2 new remote patient monitoring codes. The codes are 99470 and 99445. These are both expansions of existing New York State Medicaid RPM covered services. They essentially lower the time requirements for providers to be eligible to bill. So it's a little easier. It opens up more reimbursement opportunity. So one is for the RPM delivered by clinical staff, and one is for the RPM that's specifically for prenatal and postpartum services. And I will put a link in the chat. We just published a Medicaid update that outlines the policy and billing guidance for these codes. And then when we publish the next version of our telehealth policy manual in July, you'll see the full policy there as well. But that's it for us from New York State Medicaid. Thank you very much for your time.
Thank you. Thought I saw a question. I have one question in case you might be able to answer this, and I might have to request to unmute you again. So we'll see. I have a general question about telehealth provider enrollment in New York State Medicaid. What address do you use when registering providers that are entirely remote? Do you list the provider's home address, hospital address, to part of a health system, or specific practice address? Do you know the answer to that? I'm going to request to unmute again, see if that works.
Hi, I don't know that answer off the top of my head, but I might have to check with our provider enrollment team. If anyone's able to, was that in the chat? If I can get that in writing, I'm happy to take that back and
I'll
try to
send
get
it
the
to you.
information for you.
Okay, I'll send it your way.
Sounds good. Thank you.
Perfect. And then, this is going to be a question for state partners as well. I'm gonna request to unmute you all, and then if anyone wants to jump in, we'll go from there. Given that the state budget is not complete, the language in statute around telehealth payment parity expired on April 1st. Has the state given any thought as to what happens if it is extended in the budget and we have this period of non-compliance?
Sure, I can speak to the Medicaid side again. So that's absolutely on our radar. We're sorry for the uncertainty that this causes while the budget is in limbo. I do not have an answer of what that is going to look like, but we plan to issue some guidance once we do know. Our hope is to keep parity alive and well for sure.
Perfect. And Anna, I tried to unmute you as well. I don't know if that worked. WebEx is not our friend today.
Yeah, and can you hear me?
Yes.
Oh yes, I didn't unmute myself because I don't have a comment on that one. So I appreciate Casey's input.
Perfect. Not to call you out there. Sometimes it's hard when it's set up in this manner. Does anybody have any other questions for either state partners? We don't have any other updates as of right now from state partners, but if there aren't any other questions, I'll give you back a few minutes. If not, everybody's here. Okay, I don't see anything coming through. I will send that comment to you, Casey, and I have the email of the person who asked, so I will make sure to connect you guys for that. And whatever answer maybe you find out from there, I will also put that in the notes if applicable. So thank you guys all for joining today. Again, as I mentioned before, please register if you can in the future for the meetings, just so we have it for state reporting. If you have any presentations or individuals, projects, anything that you're interested in looking at, please let me know. I would rather guide it to what you're looking for than just overall what I think would be important or what people around me would think would be important. So please reach out for that. If you would like to share about your project or presentation, please let me know. We can see if we can get you on the calendar. And then lastly, I mentioned the summit already. I'm going to mention it again. Summit call for presenters is open. So is sponsorship and so is award nominations, and we would love to get presentation options in there. Plus, it's great to have everybody there. Oh, I do have one more thing, a question that came through. Is payment parity something that DOH is looking to make permanent, or is it dependent annually on the budget process? I might have to open that up again. Let's see. I'm not going to call anybody out this time.
Thank you.
Yeah.
Yeah, so far parity has been biannually extended it technically in public health law on a 2-year basis. So it's not every year in the budget. So far it's been a 2-year basis, and unfortunately I don't have any guarantees about what that may be moving forward.
Perfect. Thank you, Casey. I wasn't going to call you guys out, but I was going to request unmute just in case. Perfect. If you have any other questions, please send them to telehealth.org, and I'm happy to connect you to wherever you need to be connected to, or connect you to someone that might have the right answer. So thank you all for attending, and we will see you on July 20th for our next meeting. Have a good day.
Thank you.